Imaging 3.0 is an initiative of all the radiologists, all of the IT guys, all of the support people, and all of the vendors who have taken the tools and created this sort of bedwork and framework that we can use. And the idea of Imaging 3.0 is just putting it all together. Why are we doing this? And it comes down to the fact that we believe that a significant amount of imaging care occurs prior to and following interpreting the examination. But for a number of reasons, radiologists don't seem to be involved in all of that care. But we believe if we could get involved from the beginning to the end, that we could improve patient safety and outcome, our care would be more cost effective, our relevance to the healthcare system would be improved, we would have a measurable way to show how radiologists are improving population health, and we could actually calculate it in decreasing per capita cost. So this is what imaging is all about. Now, how are we going to get there? Well, number one is, I think, is the cultural shift, and that is encourage radiologists to own all aspects of imaging care, provide better, not more care, all the care that is necessary and none that's not. How do we get evidence-based medicine into our practices? Well, because clinical decision support is the start, but that's only the start, and there are lots of different ways all through the chain where we can look at evidence-based practice. We need to figure out how to empower patients in their care. How can we help patients understand radiation safety issues and their personal dose? How can we put them in charge of owning their imaging records? So when they say, well, I'm going to get a CAT scan, and the doctor says, well, you got that CAT scan, 3 hospitals over, and we can't get that, so we're just going to repeat it. Well, now we don't need to do that anymore. We've got the tools, and we need to figure out how to get patients empowered in that. And obviously, all of this is going to be the framework from IT developers to create these tools that physicians can use at the point of care. That is, right on the PACS workstation. We want to be efficient. We want to figure out who needs us to intervene and who can go through the system slick as glass. We want to figure out every bad potential outcome before it happens. We don't want report cards and say, well, you did it right 90% of the time, aren't I great? We want a tactical solution that never lets us miss. And then, frankly, we've got to align incentives. And that's changing the discussion right here in Washington with the policymakers as we move from volume-based care to value-based care. So what's that going to be? That's going to be Imaging 3.0. And I'm going to start flying now because everybody understands this. Healthcare inflation, demographics of the beneficiaries, our government predicament, and really issues in the House of Medicine. When you look at healthcare inflation, 1960, 5.2% of GDP, now 17.9% of GDP. All of a sudden, we have a whole bunch of people, pretty much all of us in this room, who are going to need a lot more health care now than we did 15 years ago. And we've got fewer people down here who are going to put the bill. Unfunded mandates of the federal government, you don't need me to remind you about what those graphs look like. And then our social justice issue of how we're going to provide medical care to people that are uninsured. Value, everybody talks about value. Here's this GDP thing, the United States is way up here in the cost of the care that we're providing. But when you look at where we are on the life expectancy chart, well, we're way down here. But it's interesting when you look at this value sort of model, and so here's what we're spending, and you look at this, so does that care that we're spending, does that actually correlate with the regions of the country where because of lifestyle people are sicker, they demand more care, that sort of thing? So right now we're looking at cost. Cost is a primary concern for the policymakers, looking at different payment models, population health and accountable care organizations. I mean, each one of these topics is a kind of a conference unto itself. But the point is that until there are alternative payment systems, fee-for-service is where we are, and payment cuts are going to be all that the policymakers are know. And of course, for imaging, everybody knows, 12 times in 6 years, and there's no point in reliving the pain, but it's just been one thing after the other. But this is a graph from the FRISC study that shows radiologist income over the last decade. And the steepness of that curve compared to primary care or even compared to general surgery is very high. Are we providing that much additional value? Maybe, but we need to figure out how we're proving that we're providing that much additional value. These guys don't think we're providing that much additional value. These guys This is Chairman Hackbarth at MedPAC. This is a Congressman, Jim McDermott from Oregon. Both of these are favoring redistribution of money in the Medicare system from specialist to primary care to the tune of about 18% for the MedPAC recommendation. And of course, we got this big RLI initiative, the Radiology Leadership Institute from the college, and so I've been going to these and I'm learning about business stuff, and so I ran across this guy, Clayton Christensen. But he talks about disruptive innovation. And so here's the deal. Here's where we are with the status quo and to new innovation. And the innovator's dilemma is that how do you get from here to here without skipping the trough? So for us, this volume drives success is where we are, to how are we going to get to where value and what we provide provides success. And so how can we avoid the trough here? So it's a lot of jugglings. I mean, we're living in the fee-for-service world. We can't just stop doing fee-for-service work and say, but we've got to figure out how to move to value-based care, sort of like rebuilding your plane while it's in the air. And to me, how can we integrate with health reform? And this is Don Berwick's triple aim for health reform: better population health, better care for individuals, and lower costs through improvements. And so what are the imperatives? What are our goals for radiology in that process? Well, it's to provide better care at lower cost, improve the health of the population, the same triple aim, right? But at the same time, we also need to figure out how we can counter the threats to our profession, promote practices that increase radiologist relevance, develop the tools that enhance the value of radiologists, and provide alternatives for us. So here's a little graphic demonstration about how we came to the name Imaging 3.0. So, starts way back when Röntgen discovered X-rays, right? So we had the new kind of ray. And who knew where X-ray was going, right? At first it was sideshows, photography. But finally, medical applications kind of took on, and starting in about 1920, kind of moved into the land of what we might call imaging 1.0, where, X-rays were typically, almost always used medical care. So it's important to physicians. We developed contrast agents, new modalities, and that sort of was where we were up till about 1990. And we come to imaging 2.0, which is basically characterized by our explosion of technology. All this new stuff, we evolved our modalities. The PACS totally changed the way we practice. We were able to expand our knowledge base. We became a consultant to referring physician. We became indispensable sort of in the healthcare paradigm. But now things are sort of changing. And that's the evolution of Imaging 3.0. And so it's going to be our blueprint for providing high-value care, taking what we do beyond just interpretation of imaging, assuring that what we do is appropriate, documenting the quality and safety of what we do and what radiologists provide, come up with actionable ways to report our results with evidence-based recommendations and follow-up, and empowering our patients. So that's what we see for the future, and that's what we're trying to promote as Imaging 3.0, sort of based on all the pillars that we think are important: satisfaction, efficiency, safety, quality, and above all, probably appropriateness. Sort of our way of leveraging our expertise to optimize care from the time imaging is first considered until patients and their referring physicians fully understand our recommendation. So maximizing our value, collaborating with other physicians, empowering patients, these are all the things, and obviously the key is our ability to change the discussion in Washington. Imaging 2.0, we said sort of is focusing on the interpretation. Our payment models are driving the way we practice. Fee-for-service, rightly or wrongly, provides incentives for more volume, and it's unfortunately pretty neutral on value. I mean, we can push value, we can push quality, but it doesn't drive it. But our practice patterns have driven what we do. To maximize our productivity, focused internally, I would suggest, on radiologists, not on the system or the patients, and not optimized for reporting quality metrics. But what it's given us is PACS and teleradiology, and above all, teleradiology has been the two-edged sword. Teleradiology is a great tool, but it really wasn't designed for regional care and distributing imaging. It really wasn't designed for patients. It could have been, but what it was really designed for was me, so I could cover our country hospital that's 75 miles from where I live without going up there every day, right? So we go up there a couple of days a week, and then we can do the rest by teleradiology. That's where it was. But obviously, it has the unintended consequences of the conduit for commoditization and the development of the national radiology companies. Presence, invisibility, relevance are all words. Presence is Keith Dreyer's word for this. So when you look at what our current tools have done for us, they have truly maximized our productivity and profitability, but they have kind of put us pretty low on the presence and relevance level. So just quickly, Imaging 3.0 is going to be for everybody: patients, referring physicians, us, policymakers. It's going to leverage IT, and I'm going to talk a little bit more in detail about where I see that going. But it's going to redefine how we see our own productivity and value. It's going to build relationships. It's going to fit with every payment system. It's going to help us with our radiologist relevance and hopefully empower our patients through things like the RSNA image sharing program and stuff. Jim Rawson says it's hard to put patients in the center if you're sitting there yourself. So we've got to worry and understand that we got to make sure that the litmus test is not totally whether we're going to get our hospital administrator or our radiologist client or referring physician to buy in, but we got to make sure first and foremost that it's the right thing to do for our patients. So this is kind of a little bit of just sort of graphically, and we can do this pretty quickly, about the sort of the three steps: before, during, after interpretation. When the referring physician considers imaging, can we review imaging history in a personal record? Can we use appropriateness criteria? Can we assure that what we're doing is safe and that the patients understand what radiation exposure for them means? On the other end, can we do decision support for radiologists with incidental findings? Can we use the RSNA Structured Reporting Initiative to help us share information better? Can we help patients share their information? And can we assure that can we benchmark ourselves with things like the Dose Index Registry to assure that we're providing that sort of care? It's all about the whole spectrum of imaging care. Some initiatives that put patients first: patient-centered radiology. Radiology Cares is an RSNA initiative. So this is not about what the college is doing. This is about sort of figuring out how we can get all of these things right at the point of care and all under the same umbrella. This is almost a fait accompli. I mean, this has been the great. This is the premier Imaging 3.0 tool. We're getting there. How we're the whole model, from how we've taken content generated by radiologists and physicians, adapted it from a big binder of stuff to a web-based product that we can use at the point of care. Now we're going through the political process of convincing Medicare and other providers that this is the tool that we need. And so we're in the process. And this needs to be the model for where the ACR wants to fit as the physicians sort of who provide the content, but then get it out there, something that we can integrate. And so everybody knows how this works, right? And it allows the radiologists and their referring physicians to collaborate, look at the decision tree, and then be relevant to the payers and everybody else. But that's just going to be the start. And it's about developing point-of-care IT tools around actionable findings and recommendations. Sort of BioRAS for the rest is the way that I look at it. How can we code the examination, and how can we provide these tools in multimedia format, and how we can provide patients access to information. This is a screenshot from an article about incidental findings done by the ACR Incidental Findings Committee for Abdominal Imaging Findings. The most read article month after month after month in the JACR. And when guys like Giles Boland and Jim Thrall and Keith Dreyer tell me that we can take grids like that and produce decision support tools for radiologists that can come up right when I'm dictating a case, I listen because I know they can get it done. And so decision support for radiologist recommendations to me is going to be a key future initiative. And we started looking at this, and these details aren't important. Just understand that imaging results can lead to either further diagnostic evaluation or change in clinical management. And we've sort of put together, Keith and Rich Duzak mainly, this sort of, we call it the 3x3 grid, and we've created an actionable reporting work group. Chuck Kahn is here. He was part of that work group. And it's going to be about communications, about structured reporting. We tried to have a good mix. Wanted in particular young radiologists. The first thing that this work group did, though, was work on what are actionable findings. And they came up with categories that we would report within minutes, within hours, within days. And then these, in the minutes, they even came up with sort of a short list that might work for the TJC. They went down through every category, neuro, GI, you kind of name it. This is a template from one vendor that Keith shared with me about how this might look when you're reporting and integrating in the medical record. But the idea here is that each EHR vendor shouldn't have to develop the content for what critical results look like, right? And this is something that the ACR wants to develop and then share so that it looks pretty much the same across. The other thing we want to be able to do is to code the exam just so we'll know how it deals with appropriateness. So for instance, a high appropriateness score at an abnormal exam, that means the exam's indicated that it was abnormal. You know, that's a perfect solution, right? But even a high appropriateness score in a normal exam is a good outcome because that directs care to some other thing. You know, you ask a question, you get an answer, oh, that wasn't it, and then you go on to the next thing. So that's very valuable imaging. Low appropriateness score, but you did the imaging consult. You talked to the referring physician, you figured out, yeah, well, let's go ahead and do that. See, even if that's normal, that's good. But what we want to discourage is the physician who gets a low appropriateness score and says, well, you know, I'm an expert, I'm going to do it anyway. They don't get an imaging consult, they get a normal exam. These are the bad actors, and if we can figure out how to educate those folks, that's what we're looking for. Patient access to information, the RSNA image share program, being able to take stuff from the RIS, the PACS, the EHR, distribute it to patients so we can kind of prevent doing this stuff. And I'm pleased to report that I think that the college and the RSNA is on a great pathway to collaboration. And so we looked at, when the college leaders and the RSNA leaders, we looked at our grid of all the IT things that we were doing, and we said, okay, anywhere it says compete, we're going to collaborate. Now, it's easy to talk, but hopefully that's where we're going to be. Now, this is something different. This is where the IT committees have looked at the initiatives versus imaging 3.0 mentality. That is, before imaging, during acquisition and interpretation, and ACR, and after imaging. And you'll just look at some of the places on this grid, you know, where there are opportunities. So now we get all these great tools, and look what happens to our curve, right? Remember, we had the curve that looks like this. Well, now the curve looks like this. So this is great, right? Our performance and relevance have really gone up. But look at profitability. That makes it a tough nut, right? Nobody wants to do it. So we got to figure out how to align incentives. And so this, again, to me, is the ideal role for the college, to work with the, you know, to work up here in Sodom and Gomorrah and work with these policymakers to figure out how we can align our incentives. So if we can get policymaker buy-in and at the same time win over clinicians and radiologists, then we can change public policy, we can change physician behavior and improve patient care, and maybe, just maybe, we can get this graph to look a little more like this, where we can help maximize our profitability. Another front where the ASR and RSNA are going to collaborate, Mary Mahoney and I are going to do a combined Imaging 3.0 and Radiology Cares presentation at this year's RSNA, so I'm excited about that. But here's where our grid's helping, right? Because look at this gap on our patient care-centered processes. So here's one of the challenges for you guys in developing these tools, and this is sort of putting it together and looking at this. It shows us where we can fill in the blanks. So tools to modify the schedule for exam details, how to go from scheduling to automatically protocol in the machine. So reaching the tipping point. Turns out you really only have to win over about 16% of the people to get to the tipping point on a new innovation. And so this is what our messaging is about. We've got a CMMI grant proposal in that we're looking at, so people will think that we're a relevant player. It doesn't matter whether we get the grant or not, in my opinion. It has more to do with the exercise of saying that this is where we are, this is what we're doing. If you come to the ACR website, you can find all this sort of stuff. We're trying to get this message out everywhere we can. These are just a couple of statements from our grant application about how Imaging 3 will save money and provide better care. You look at our case studies, sort of different ones that show all this stuff in action. So here's the grid. It's not just us, it's the vendors, the payers, other providers. And so in summary, going from volume-based to value-based, a transactional system to a consultative system, from being radiologist-centered to systems and patient-centered, interpretation-focused to outcomes-focused, a commoditized product to integral to the healthcare, and going from invisible to accountable.